So some emerging trends in acute pain management are multimodal analgesia and trying to combine different medications or modalities to actually treat the cause of pain. So of course, as most people know, we are in an opioid crisis, and opioids are a very strong pain medication and very necessary. But in patients who have acute inflammatory pain or maybe acute neuropathic pain, opioids are not necessarily the first line treatment because they actually don't really treat the cause of pain. But if there is inflammation or there is a neuropathic component, there are new medications or new ideas about how we can actually treat the source of pain. So combining different medications that alone may not provide adequate analgesia, but together through synergy can really drive pain down is a nice approach, and that way we can avoid some of the opioids in patients who are not taking them. And why would we want to expose them to something that potentially has the risk of dependency if we can get them out of pain without it? The goal, of course, yes, is to perform an intervention or combine a short course of medications to prevent the progression of chronic pain. And a major initiative right now is to keep patients opiate naive if they're presenting to us opiate naive. We know when we prescribe insulin or Coumadin, we have lengthy conversations with patients about the risks, morbidity, and mortality. We're prescribing very strong medications. And when we are giving opioids, I think there is a lack of an understanding about the strength or significance of what we're prescribing, and certainly there's not a focus on education. If you're going to prescribe the opiate, you really must do the appropriate education. A lot of physicians in the acute care setting, which is very busy, may not have the luxury of that time, but being empowered with the knowledge to reach for alternatives, which do have less side effects, although every medication does have side effects, that education is different. Maybe stretching, physical therapy, but it's not that significant discussion about the risks you're exposing that patient to when you are starting something as strong as an opioid. Additionally, nitrous oxide is gaining popularity because it is a wonderful analgesic but also anxiolytic agent. When we use it in the emergency department, we typically use it as a single agent, and we try to avoid procedural sedation. So procedural sedation is a cumbersome resource utilizing method of putting a patient to sleep so you can do something painful. With nitrous oxide, it is a strong analgesic, it is a strong anxiolytic, and patients typically have enough relief where you can do an incision and drainage, do a small joint reduction, foreign body removal, and the gas is inhaled in combination with oxygen, works within a minute. You use it for the duration of the procedure, and when you turn it off, the patient is back to baseline very quickly. They can be discharged with no restriction at all. You've used no procedural analgesic agents, and you've used no opiates as well. You know, no one wakes up in the morning and says, I want to be addicted to opioids. But it happens ever so slowly, and a lot of opioid prescribing is well-intentioned. You don't want your patients to suffer. If we can empower physicians and patients to know what's in the toolbox to address pain, we can try to use opioids as a last line. They're always going to be there, and they're so necessary in some cases. But for a lot of mild to moderate pain, inflammatory pain, for example, really doesn't need that opioid as a first line. And the more we use it as a first line in opiate-naive patients, the more we increase the risk of dependency and opioid harms down the road.